It's a pleasure to be with you today, and I'd like to start by thanking Dr. Forrest and his team for the amazing work they've done in learning health system science, particularly around the definition of competencies. And I'll just preface my comments by the fact that I'm trained as a clinical scientist, primarily in the context of clinical trials. I've done a lot of good intervention research in partnership with health systems, but I am I think a partner along with health system scientists, learning health system scientists, and I hope to become a more informed consumer and collaborator of that process. So this is a useful process for me as well. I was asked to speak with you today, just given my current involvement in graduate research training programs in rehabilitation, to reflect a little bit on maybe the gaps between the learning health system science competencies and what we see in our rehabilitation research training programs that exist. So I'll talk just a little bit about that. What I decided to do as a point of reference is to take a look at 3 top-tier rehabilitation research programs. I'm not going to name them, but that are well known by reputation, that generate a number of graduates within the field of rehabilitation science, and to take a look at what I saw in their curriculum based on publicly available information. This is a very high-level comparison, not terribly rigorous, so I preface my comments with that, but just to take a look at, to start the conversation in terms of what are the opportunities within rehabilitation for training our future scientists as learning health system scientists, and where are some of the gaps as we start to think about that. So as I understood it from Dr. Forrest's comments, he was talking about imagining a piece of paper. Hopefully I imagined what he was describing, but at the center is the people or the population that you're seeking to help serve. And surrounding that, it's the application. Learning health system science is the application of applied clinical research methods, improvement and implementation science methods, certainly informatics using health system or clinical information data, and stakeholder engagement, which is multi-level, multifaceted. So not just the people in the populations, but providers, health systems, payers, policymakers. And that it's this collective that brings about learning health system science. And so when I thought about that relative to the 3 programs that I'm going to talk to you about in a moment, rehabilitation science, I think, has included good training in applied clinical research, but usually in the conduct of controlled studies, even studies in the home and the community, but not nearly on the scale that I see that happening within learning health systems or relevant to some of the topics that Dr. Forrest shared within the competencies. Stakeholder engagement, I think, has been a really important discussion in rehabilitation science in the early days. Participatory action research was a key component of rehabilitation science training. But what I don't see in our programs is a significant investment in that multi-level simultaneous engagement of people and families and communities, advocates, policymakers, administrators, providers, and how to facilitate those conversations among those stakeholders to move towards a movement forward. And I'm not aware within the rehabilitation science training programs, certainly within health services research training programs, but not within rehabilitation science training programs, of much emphasis in the improvement and the implementation science methodologies or informatics per se. I decided to take a closer look at the domains that Dr. Forrest outlined for us, and I'm going to start with research methods because I think that might be where we have the strongest comparison, perhaps. When I looked at, again, based on website information, publicly available information, coursework, focal experiences, training experiences within these graduate rehab training programs, I saw some evidence of exposure to pragmatic studies, clinical trial design within those environments, but not really at the level of large systems of care or community system engaged care. We tend to have strong training in mixed methods design, again, stakeholder engagement, but really at the level of an interaction with the clients or people receiving our services, and much less so at the level of providers and health systems, and not a lot of emphasis on complex intervention design, which is a methodology and a set of skills that are important in of themselves. I saw little evidence of training in system science. training in how health systems organize and operate themselves, which would be critical, obviously. Trainings in systems theory, complexity theory, and some of the elements that I think are specific or are unique are critically important to learning health systems science. Dr. Forrest talked about the ability to develop meaningful questions as defined by stakeholders, and to be able to translate evidence to the local context engaged with these systems of care or stakeholders. Again, I think we see some evidence of that in rehabilitation science at the level of intervention program development, perhaps. But many opportunities to really explore growth in that area and within our training programs. In informatics, there are a few programs that I know of, not the programs that I looked at that include some training in informatics, and that usually has to do with whether they have access to people with expertise in informatics. Certainly, students in rehabilitation science training programs get access to concepts of data integrity, data quality, data sharing, but not in the context of complex data that we see in electronic health records, clinical information systems, community health systems, where the nature of data are quite different. And so I think this would be an area or a gap that could be explored. Again, rehabilitation science graduate students often have great training in ethics, but I think we encounter specific ethical issues within learning health system science. I think Dr. Forrest talked about a few of them. But when you're engaging with medical record data and clinical information data across systems, you're really engaging with a new level of ethics. When you're exploring improvement and access to services, a whole new level of ethics that I think requires additional training above and beyond what we're currently exploring in our programs, at least in the programs that I've surveyed. I didn't see, and I was surprised to see this, much evidence of discussion around the differences between research and improvement. And I agree with Dr. Forrest, it's not a distinct black and white thing. There's some gray there, but I'm not clear that we're having those discussions at all. And I suspect that that is something that bears further exploration. And then with respect to improvement in implementation science, I did not see a lot of evidence of training in these elements among our programs. Engagement in leadership and management. I think the distinction between what we do with our current rehabilitation science graduate training programs and what I think would be necessary for a learning health science team scientist is that team science is not necessarily comprised of PhD or MD trained members of the team. We often are engaging community members, advocates, people with business or finance backgrounds, people with administrative expertise. Certainly patients and families who have the best expertise through their lived experience and their day-to-day challenges in managing health. And I think it takes a special training to train a team scientist to formulate questions, formulate a vision of research program, and to engage those complex teams in work that moves forward in a productive manner. And then with respect to health, equity, and justice, I was pleased to see that there is coursework within our rehabilitation science programs that are really much more focused, I think, on educating ourselves, understanding the impact of structural barriers or structural biases, understanding some of the social inequities that exist, and creating an awareness, but probably less emphasis on how to formulate questions, how to surveil, how to engage with health systems or community health systems to influence change and bring about large systematic change through improvement implementation methods. So my brief analysis is this, that, oops, I apologize. My brief analysis is this, that we have work to do if we are to embrace what Dr. Forrest is talking about, the proliferation of competencies across disciplines to really prepare those who are coming from a rehabilitation background or invested in rehabilitation to get them up to speed in these competencies. There are several areas of weakness that I identified. And I think there are a couple of things we can be thinking about. Certainly, we can be identifying learning health system training programs that exist. And as we identify people among our communities that are interested in that direction, partnering to facilitate connection with those students so they can get that training, I think would be key. I think thinking about reframing some of our rehab science programs. Some of the programs I look at have training tracks in basic science, clinical science. You know, what would be the capacity in some of our institutions for creating a track in learning health system science, but understanding that this needs to be a focal, full-fledged, and invested, embedded training effort in order to achieve competency in these very complex methods. And a different way of thinking, the way many rehabilitation scientists are currently trained. So with that, I will pause.